All right. Thank you guys for having me today. My name is Beth Zhou. I'm a full-time reproductive endocrinologist at CCRM in Houston, but I did my clinical fellowship here at UCSD and really fell in love with the research working with Dr. Zhou. So I'm still affiliated on a voluntary basis, primarily doing the data analysis and looking at administrative data sets and trying to understand access to care and oncofertility outcomes. So the question that the main question that we're trying to answer now is, what is the impact of insurance mandates on the utilization of fertility preservation services among reproductive aged females with cancer? And in order to answer this question, we want to first understand who our population at risk is. So we utilize the NCI's SEER data set to just understand the number of reproductive aged females at risk in the time periods that we're looking for. The other data set that we're interested in is the data set available through the Society of Assisted Reproductive Technologies, or SART, which is basically a data set of all the IVF outcomes and characteristics of cycles done by 86% of the IVF clinics here in Houston. So a potentially pretty powerful data set, primarily because they have two indicator variables of interest to us. One is the fertility preservation indicator, which basically tells us that this specific cycle was started with no intent to utilize any eggs or embryos that come from these cycles. And then the second is this field that became available in 2016. That's the genetic toxicity indicator, which basically tells us that when this field is selected by the clinic, that this fertility preservation cycle was specifically done prior to a gonadotoxicity. So it can help us kind of differentiate whether or not a fertility preservation cycle was done for social reasons, such as delayed childbearing, or was it done for medical indications. When we look at the SEER data set, it's evident that the number of new cancer cases among females of reproductive age, for our definition is 10 to 49, remains relatively stable between 2012 and 2021. There is a slight dip in 2020, but that is a known effect from the COVID-19 pandemic. When we then analyze the number of fertility preservation cycles in general among states with various insurance mandates, we notice a couple of patterns that are of interest to us. The first thing that we notice is that the number of fertility preservation cycles appears to be increasing over this time period, regardless of mandate status. So for example, in the solid black line, states that don't have any IVF fertility preservation mandate already are experiencing an increase in fertility preservation cycles. We can also see that fertility preservation mandates that become after this time period of interest, meaning we don't have any post-mandate effects here, they already have a small but persistently higher utilization rate compared to the states that do not have any mandate whatsoever. So this kind of this suggests that there might be some kind of a difference between the states that are considering passage of a mandate and versus the states that do not have one. And this is further highlighted by the fact that among states that did already pass a mandate, such as New York in this example, in the purple line, we can see that there's already an increase in utilization even prior to the passage or the effective date of a mandate in 2020. Finally, what we also note is that when we use this broader indicator variable of fertility preservation, which we know will capture fertility preservation for other reasons, the rate of utilization, even among states that have a mandate, ranges from 5 to 55 people per 100 cancer cases. So we can imagine that if we narrow down that definition of fertility preservation to who is actually undergoing this for medical indications, that rate of utilization will be lower. But how much lower does it get? To do this analysis, we use that gonadotoxicity indicator. So we are looking at 2016 to 2021 here. And what we see is that when we use this new definition that's more specific to medical indications, we can see that that rate drops dramatically to 0 to at most 2.5 people per 100 cancer cases. We also can see the same uptrend in the number of cycles among states that either have no mandate or no active mandate during this time period. And then when we hone in on all of these colored lines that make up the states that did pass a mandate during this time, so we can see a pre and post mandate effect, we can see that in general, there doesn't appear to be a significant difference in the number of fertility preservation cycles before or after the passage of the mandate. Okay. So we observe that there's an overall increase in the number of fertility preservation cycles for all indications over time, regardless of the passage of the mandates, which may be reflective of societal changes or overall improvement in access to care for these services. But it's unclear what the actual effect of the mandate can be. The other thing that we've noticed is that, again, number of fertility preservation cycles prior to gonatotoxic therapy with using that flag is overall low. But what we don't understand is this reflective of a true low utilization of fertility preservation for medical indications, or is this a effect of not flagging our cycles correctly? And the answer is realistically probably somewhere in between. And the true rate of fertility preservation for iatrogenic reasons lies somewhere between the two figures that we showed before. From this study, then obviously we would want to understand what is that true rate of fertility preservation prior to gonatotoxicity. There are different ways to be able to help us understand this. This might be through linkage through other data sets, such as through SEER, or through administrative data sets where we can identify a different cohort in a different fashion. When we see that that there might not be any differences between before and after a passage of a mandate, this suggests that sometimes these mandates are just not addressing the true barriers to accessing these services. So improvement in language in these policies, such as expanding eligibility criteria or mandating specific coverage details, may be part of the true solution in improving our access to care. With that, I wanted to just thank our team. I'm trying to move forward. There we go.